Good afternoon, everyone, and welcome to the Menopause Unmasked, Supporting Women Through the Transition webinar brought to you by Univera Healthcare. As many of you may be aware, October is National Breast Cancer Awareness Month. So with the heightened awareness around women's health in general this month, we have heard feedback from our customers that menopause is a hot topic, no pun intended, and interest for many. So we really thought it was the perfect opportunity to leverage one of our own health plan experts to discuss this topic. So we're excited to have so many of you here joining us today. Now, I want to start out by thanking each of you for taking the time out of your day to join us for our monthly webinar, part of the Understanding Your Wellbeing webinar series. If you are new here, my name is Katie Keller-Burgess, and I am part of the wellbeing team here at Univera Healthcare. So I will be the host for today's webinar, really teeing up our guest speaker, Dr. Kathleen Robichon. So today she will be pulling back the curtains on a topic that is often whispered about, but really truly deserves center stage to be talked about, if you will, which is menopause. Now, this transition is a natural part of life, yet it can feel anything but simple. So that's why we are here to unmask the myths, share some facts, and really try to empower those on this meeting through the transition and knowing what resources and available support there are. So a few housekeeping items that I do want to start us off with here today. Please note that today's webinar and all of our 2025 wellbeing webinars are being recorded and housed on our Univera Healthcare YouTube page. So if you need to go back and listen to this webinar or maybe access a past webinar topic that we've done, once again, you have on-demand access to those monthly webinars directly through our YouTube page. And I'm going to give a plug to my colleague Kate here. She's actually going to put that YouTube link directly in the chat. So if once again anyone is interested in checking that out. The other thing I want to note is that all participants' microphones and videos are automatically disabled. Now there will be time at the end for questions with Dr. Robichon. So if you do have any questions throughout any point, please feel free to enter them into that Q&A. And once again, at the end, based on time, Dr. Robichon will be able to address any questions that have come through. And lastly, it is important to note that the content covered here today is meant to be educational in purpose. Of course, if you have any specific health-related questions or concerns, we recommend that you connect with your primary care provider or possibly OBGYN. Or if you have any benefit-specific questions or concerns, we recommend to call the customer care number on the back of your Univera Healthcare member ID card. So with that being said, I have the distinct pleasure of introducing today's guest speaker on this topic, once again, Dr. Kathleen Robichon. She is the Vice President of Medical Affairs for Clinical Services here at Univera Healthcare. In her role, she provides strategic clinical leadership across different areas, including utilization management, medical director team operations, as well as quality programs. Now, she has been instrumental in advancing the health plan's initiatives in cardiology as well as maternal health, driving innovation as well as improved outcomes for our members. And prior to joining the health plan in 2019, Dr. Robichon practiced as an OBGYN physician in the Rochester area for over 2 decades. Her deep commitment to women's health continues to shape her work, particularly around the area of menopause education. So she has delivered numerous lectures, empowering women with knowledge and once again fostering open conversations around menopause. So once again, she is known for her passion, clinical insight, and dedication to improving care through education as well as advocacy. And she was more than happy to step in here today when asked to support this webinar on menopause. So Dr. Robichon, we are so grateful to have you here today. With that being said, I will turn the stage over to you.
Thank you so much, Katie. I appreciate it. All right. I want to thank everybody for attending today. I am very excited to be able to speak with all of you on a topic that affects so many of us at some point in our lives, menopause. We're going to cover some important facts about menopause, talk a little bit of the stages of menopause, understand what's happening hormonally, symptomatically, and how we can manage and treat these symptoms so that we can, and also how we can support one another through this transition, both personally and at work, because there's a lot that really needs to be understood and supported as women go through this. So, what is menopause? Well, by definition, menopause is 12 consecutive months without having a menstrual period. And I have had many a patient who came in 11 months into the process and then they got a period, and I had to give them the bad news that the clock is starting over. We got to start counting again, and it's got to be 12 more months. So it's a lot. Hopefully, I can give you some information that is useful and can help you through this process. The average age of natural menopause in the United States is 51. There's about 50 million women somewhere in this menopause transition continuum. The process with perimenopause and menopause can last on average 8 years. It can be longer. For the fortunate people, it can be shorter. And there's also about 5% of the population that has premature menopause, meaning under the age of 45, for reasons that we don't understand. And there's some unique components to how we would manage them as well, which I'll talk to a little bit. But menopause is wildly unpredictable. Periods change dramatically. You can have very heavy, more frequent periods. You can have much lighter, less frequent periods. It's generally a very confusing time and it catches a lot of us by surprise. So no, it's not just you. Like I said, the transition can take about 8 years. Most of us will start in our mid-40s, some earlier. We break menopause, perimenopause down into two parts. There's early perimenopause, and this is when your periods can still be regular. They might change a little bit. The important thing to know about this time is you're still potentially ovulating. You can still get pregnant. So if you're not using some form of birth control, you might end up with an oops late in life baby. We don't want that to happen unless that's your plan. So it's important to pay attention to that. The late perimenopause is when things start getting a little more wild, periods unpredictable, hot flashes, night sweats, all of that starts to happen. Again, menopause is that 12 months without a period. And then there's early postmenopause, which are the first 4 years after you stop having periods. And some things happen during that time that can be interesting. And then late postmenopause is basically after that 4-year period of time ad infinitum. So all kinds of things happen during that time frame. Menopause is typically associated with decreased production of estrogen from the ovary. In a normal reproductive time period, there are hormones called gonadotropins that are released by the pituitary gland that stimulate the ovary. They want to produce an oocyte or egg because the goal of every cycle, according to the body, is to create, have fertilization happen and create an embryo. So the ovary produces lots of estrogen and progesterone. When we get into perimenopause and menopause, that ovaries don't respond well to those gonadotropins. There is no egg being produced. Estrogen and progesterone levels drop. And that's when we start to see the symptoms in our bodies of lower estrogen. I will say, again, youth is wasted on the young because estrogen does so many amazing things in our body before menopause. It protects our cardiovascular tissue. It helps keep our blood pressure stable. It keeps lipid levels healthy. It is actually protective to our brain by helping maintain proper blood flow. Estrogen helps in assisting with memory and fine motor skills. Estrogen is, there are estrogen related proteins in the brain that boost mood and help with keep serotonin levels even. We know that estrogen works with our lean muscle mass and our bones to protect against osteopenia and osteoporosis. And also estrogen helps to keep the vaginal tissue healthy, promote vaginal lubrication, and prevent painful intercourse. So lots of good things that estrogen does for us. Progesterone also does some good things. Its main role is to stabilize the lining of the uterus so a pregnancy can implant, but it also plays a role in mood. It does some work in supporting thyroid function, and also plays a role after delivery of a baby with lactation. So many things that these hormones do for our bodies. Menopause can affect almost every aspect of a woman's body from head to toe. We're going to talk about how that plays out. Estrogen, about 75% of women will experience some sort of vasomotor symptom, hot flash, night sweat, that kind of thing. About 50% of women as they go through menopause will develop symptoms of vulvovaginal atrophy, vaginal dryness, painful intercourse, all those things. But there are many things, many things and symptoms that are diverse. We know about a lot of them. Irregular periods, hot flashes, night sweats, weight gain, all of those kind of get a lot of play. The brain fog, changes in libido. But some things don't get a lot of play that can also be kind of debilitating. One is something called burning mouth syndrome. Estrogen does a lot to stabilize our oral mucosa. And when you go through menopause and estrogen levels are lower, you can start having a dry mouth or altered taste in your mouth, or even this burning sensation. The good news is we can treat it. Treatment can be saliva substitutes, some oral pain meds, even thinking about menopausal hormone replacement therapy, which I'll talk about later, supplements like vitamin B and zinc. So there is treatment. Another area that doesn't get a lot of play is that estrogen is an anti-inflammatory, and it really works well on our connective tissue. It helps promote elasticity and strength in our muscles, tendons, ligaments. And what we see happening is as estrogen levels drop, we can have increased joint pain. And one of the places that we see this a lot is in areas that are prone to overuse. So it's hips, knees, shoulders, elbows. And one of the biggest ones that is completely misunderstood is something called gluteal tendinopathy. This is a very deep hip pain, often misdiagnosed as osteoarthritis in menopausal women, but it has to do with the almost brittleness of the gluteal tendon that happens. And it can be very painful to the point where you need to take some pain medications, anti-inflammatories, or do physical therapy. We see something similar in the Achilles tendon and also in the shoulder. And people can complain of frozen shoulder. So while there's lots of things that happen, those are some of the unusual ones that are starting to get a little bit better understood now. As I mentioned before, estrogen has anti-inflammatory and vasodilatation properties. It also contributes to a favorable lipid profile, meaning we have higher HDL or good cholesterol and lower LDL or bad cholesterol. All of this works to be cardioprotective for women. But as women enter menopause, their risks for cardiovascular disease start to increase. We produce less estrogen. This protection on our lipids and blood vessels start to wane. Studies show that arteries become more vulnerable to disease. They get thicker and stiffer. We see increased abdominal or belly fat in menopause. And there's also an increase in what we call visceral fat, and that is fat around our organs. And all of these work to increase our cardiovascular risk factors and can increase insulin resistance, which can also lead to type 2 diabetes. And studies have shown that the cardiovascular risk factors in women approach that of men 10 years post last menstrual period. So typically, if we're talking about age 50, 51, we're talking at around 60. So this is why this is so important, because as we get farther away from that last menstrual period, we are now developing risk factors that affect all aspects of our life. And so the reason I'm showing this slide is we use this, it's called the ASCVD. It's an atherosclerotic cardiovascular disease risk assessment tool. And this is part of what can help to determine what are the best therapies to treat women as they go through menopause. We want to look at your past medical history. Do you have high blood pressure? Do you have diabetes? An autoimmune disorder? What were your pregnancies like? Did you have gestational hypertension or gestational diabetes? Did you develop preeclampsia? All of those can be little warning signs or risk factors for later cardiovascular disease. We look at family history, social history, lifestyle. There are some biomarkers and labs that we can look at. And all of this gives us kind of an assessment of where someone's cardiovascular risk is. And this becomes important as we decide on therapy. And I'm going to talk about that more later on in the talk, but laying the groundwork for it. And previously, I told you a little bit about how the hormonal changes with menopause kind of start in our ovaries with low estrogen production. But many of the symptoms that we see in menopause, hot flashes, night sweats, brain fog, insomnia, memory lapses, actually start in our brain. And part of this is because premenopausal levels of estrogen and progesterone are actually protective to the brain. They are involved. They are located in regions that are involved in learning and memory, such as the prefrontal cortex, the hippocampus, the amygdala. It also helps to regulate energy in our brain and supports immunity, as well as cellular growth and communication. During perimenopause and postmenopause, these estrogen levels start to decline, and that's when we start to see the brain fog, the memory issues, some emotional lability, difficulty with sleep, and more. And some studies have shown that women who go through early, either surgical menopause or early menopause for reasons we don't know, have increased risks for dementia. So it's really important that we understand what's happening and that we intervene so that we can make sure that people are getting the adequate diagnosis and adequate treatment so that they are not at higher risk for these things. And I am going to repeat a very common theme throughout this talk about things that we can do as women to protect ourselves and support each other through this. It's going to come down to things that sound simple but are difficult, and I feel like if I say it enough, it'll start to sink in a little bit, but it's going to be like eating a healthy diet, getting exercise into your regular regimen, working on getting enough sleep, and we'll talk about some things with that, reducing stress, avoiding environmental toxins like tobacco and alcohol, which can have adverse effects on our cardiovascular system, our brain, all kinds of things. Another thing that's crucial is maintaining social connections. It's important for our brain and memory. It's important for helping to minimize or decrease the risk for dementia. We want our world not to get smaller. We want to keep those connections so that we can continue to feel good about ourselves. We want to stay mentally active. And most importantly, we want to stay connected to our healthcare provider so that we can make sure that as we are going through this process, we are identifying what risk factors we have, what can be beneficial to us, and what we can do moving forward. And I apologize for the inability to read this slide very well, but I want to make a really important point. The point is that this shows several different ethnic groups, the average age of menopause, the most severe and most frequent symptoms they have, because what this goes back to is we all have very different menopause experiences. It is not all alike. We are very different. For instance, Black women tend to enter perimenopause and menopause at earlier ages than their non-white peers, than their white peers. They have a longer perimenopause transition, and they tend to experience hot flashes and vaginal symptoms more severely. There was a study called the SWAN study that looked at ethnicity and hot flashes and night sweats. And what they found was that for non-Hispanic white women, it was about 6.5 years duration. For Latina women, it was 8.9 years. And for Black women, it was over 10 years. The reason that we need to know about this is the longer you are in this phase and having symptoms and not being treated, the greater your risk for developing diseases later on in life is, like cardiovascular disease, osteoporosis, even dementia. And it's really important that we, as women, as consumers of health in the healthcare world, know what our risks are and know how to advocate for ourselves. And I would like to educate providers on this too, so that we know that providers are understanding this as well, because my motto is related to menopause, that women should not suffer in silence. And part of this is giving a voice to this so that we can advocate for ourselves. I think that's a really important part of this. I am going to talk now a little bit about some treatment options. Menopausal hormone replacement therapy is the broad term that we use to describe giving either estrogen alone or estrogen and progesterone for women who are having symptoms related to menopause. It is important to know that the FDA has only approved hormone replacement therapy to treat vasomotor symptoms related to menopause. There are no other FDA indications for hormone replacement therapy, even though it works for them. So when we prescribe it for something else, technically it's an off-label indication for using it. There are many different formulations that it comes in. When we think of the traditional hormones used in hormone replacement therapy, the one that's most famous is conjugated equine estrogen. This estrogen actually comes from the urine of pregnant horses. We have some estradiol, which is a bioidentical, and then synthetic estrogen. And there are some people who should not ever take hormone replacement therapy or estrogen replacement therapy. If you've had a history of breast, ovarian, or endometrial cancer, you really shouldn't. Those are estrogen-based cancers for the most part, and it really is not recommended. If you are having unexplained vaginal bleeding, not a good idea to be taking estrogen. That can make it worse. We want to make sure we have an understanding of why that's happening and treat that first. If you've had a history of blood clots or a pulmonary embolism, we would not want you taking estrogen. And I'm going to talk a little bit more about, how we should do this. Typically, we want to start estrogen replacement therapy within the first 10 years of menopause, and certainly before the age of 60. There are some studies coming out that if we're worried about estrogen potentially causing breast cancer, we might want to put a limit on how long women take hormone replacement therapy. Typically, if it's estrogen alone, and we would only give estrogen to someone who's had a hysterectomy, they no longer have a uterus. The feeling is that if you take it for less than 7 years, there should not be an increased risk for breast cancer. If you are taking estrogen and progesterone, and we give progesterone for women who have an intact uterus to minimize the risk of them getting endometrial cancer, it's more in the range of 3 to 5 years, so it's a much shorter window. And again, it depends on certain formulations of those hormones as to what we would recommend. But I will tell you, when I started practice in the previous millennium, the idea was, you just start people on hormone replacement therapy, everybody gets the same thing, and it's for the rest of their lives. We have clearly moved away from that. We really are looking at more personalized treatments that fit an individual. I will briefly touch on testosterone can also be used as part of this menopausal hormone therapy. It's typically given to women for sexual dysfunction or low libido who have not responded to estrogen and progesterone therapy. Okay, this is what I like to call a shared decision-making model to develop a personalized treatment plan. The first step, in my mind, is to identify risk factors. And first off, I'm going to identify the people that I don't think should get any form of estrogen replacement therapy. Again, people can be willing to take on certain risks, but I, as a physician, can also accept risk. And there are certain risks that I'm unwilling to accept. And and that would be someone who has coronary artery disease or peripheral artery disease, has had congenital heart disease, because that puts them at more risk for problems related to being on estrogen, any prior pulmonary embolus or deep vein thrombosis, if they've had a stroke or TIA or had a heart attack, really not candidates. And I referred to that ASCVD before. If their 10-year ASCVD is greater than 10%, they really should not be thinking about doing estrogen replacement therapy or hormone replacement therapy. The easy thing is the low risk people who are, recently menopausal or in perimenopause, more the late perimenopause. They're close to their ideal body weight. They have normal blood pressure, physically active. Their 10-year ASCD is less than 5, and they're low risk for breast cancer, and they're symptomatic. I want to treat those people. I want them to feel better. Those are people that I would consider some form of hormone replacement therapy. It's the intermediate risk people that are the hardest, because some of these can be absolutes. I think if someone's high risk for breast cancer, I'm going to try to talk to them about other options than hormone replacement therapy to manage their symptoms, because I don't want to put them into a even higher risk. Somebody who smokes, I'm really not comfortable giving estrogen replacement therapy to someone who's smoking. So again, it really is like an individualized thing. And I would have serious conversations with people about how we're going to do this. I would have frequent check-ins to make sure that the dose they're on is working. The idea is really we want the lowest effective dose for the shortest amount of time. So, and that's really a lot of trial and error sometimes. Bioidentical hormones, these are hormones that are derived from plants. They are chemically identical to the hormones that are in our body, but they are typically modified in a lab to be able to be used for human consumption or however we decide to use it. They also come in very similar pills, patches, creams, gels, are very common. The FDA has actually approved some bioidentical hormones. The estrogens go by the name of estrase, Climera, and Vivel, and the progesterone is Prometrium. So those do have FDA approval for being used as bioidentical hormones. There are other types of bioidentical hormones that can be made in a pharmacy. Typically, they're made according to the instructions of a physician. This process is called compounding, so you have to go to a compounding pharmacy. Those seem to be getting harder and harder to find, although I think they can do mail order compounding pharmacies now too. The compounded bioidentical hormones are manufactured and sold without FDA oversight for safety, quality, and purity. And so the problem is that this makes it hard to know that you're exactly what you're getting. And sometimes you may not get the same composition from dose to dose. So it may create a little more variability in how it's controlling your symptoms. Many women are interested in things that are not hormonal. They don't want to be involved in hormones, but they're having symptoms. And a lot of this what we give them depends on what symptoms they're having. So if it's really just problems with intercourse or vaginal dryness, you can use over-the-counter vaginal moisturizers. There is a vaginal insert that's a prescription called dihydroepiandrosterone. The brand name is Veoza, and that can be used for sexual function to help. There are many medicines that we have found that help with hot flashes. Antidepressant like paroxetine can help control hot flashes and may have a benefit if you're having some depression or anxiety. So you get a little 2-for-1 there. There are some selective estrogen modulators or SERMs that can work with hot flashes and painful intercourse. There's an anti-seizure medicine called gabapentin and a blood pressure medicine called clonidine that actually also help with hot flashes that can be very beneficial. And then there's some plant and herbal supplements that I'm going to talk about a little bit more in the next slide. Essential oils can actually help with some of the symptoms of menopause. Also, avoiding triggers. I already said how, smoking and alcohol can affect estrogen levels. They can affect sleep. Um, Spicy foods can be a trigger for hot flashes. Um, my common theme is going to be exercise, healthy diet, sleep, and stress management can also be used to help alleviate some of the symptoms of menopause. Not easy, but certainly available. Herbal supplements, there are many. They typically fall under the category of phytoestrogens. Phytoestrogens are plant-based compounds with a similar structure to estrogen and have estrogen-like effects on the body. Examples are isoflavones. Soy is the most common isoflavone that we hear about. There's lignans like flaxseed. Um, I think ginseng is a pretty popular phytoestrogen that people like to use for dealing with some of the symptoms related to menopause and perimenopause. There can be side effects to these medicines, so that's something to pay attention to. Ginseng in particular can interact with the blood thinner warfarin. So I wouldn't want someone who's on warfarin taking ginseng because that could be detrimental to them. There's, chasteberry, valerian. Valerian's been shown to help with insomnia, anxiety, headaches, and stress. Red clover, black cohosh. Black cohosh is another phytoestrogen that's gotten a lot of attention, lots of studies done on it. It definitely does help to manage hot flashes very effectively. Ginger. Green tea is a little different. Green tea is a polyphenol, and this green teas actually has some anti-inflammatory effects on the body, so it can actually be helpful dealing with some of the issues related to joint pain, which would be very helpful. So I highly recommend having a discussion with your healthcare provider before taking any herbal supplements to ensure that it's safe for you, it doesn't have any potential risks with other medications you're taking or health conditions that you may have, because while they can work very well, they can also have some negative side effects that we want to try to avoid. Okay. So we're going to go on to other parts of the body now, our bones. So bone density naturally declines with age. We get peak bone mass around age 30, and then it just starts falling apart. Estrogen is very protective to bone. It actually promotes bone-forming cells to work. As estrogen levels decline during menopause, there is an acceleration of bone loss. This can lead to osteopenia, which is thinning bone, or osteoporosis, which at that point, our bones are at increased risk for fracture, particularly in the hip, arms, and spine. It's really important that we understand other things that can impact our bone. Smoking impairs bone health. Chronic alcohol use interferes with calcium absorption in our gut, and that affects bone formation. Lack of weight-bearing exercise and being physically inactive can reduce bone strength. Certain medications can have effects on our bones, corticosteroids, anticonvulsants, some cancer treatments, as well as diseases like rheumatoid arthritis, diabetes, and thyroid disorders. That's why it's really important to talk to your doctor to find out what your risks are and what we should do. We do manage looking at bones with DEXA scans that can actually measure bone mineral density and tell us whether you're at risk for osteopenia or osteoporosis. There's also something called the FRAX tool that estimates the 10-year fracture risk, and it includes clinical stuff as well as bone density. Calcium and vitamin D, very important. Our bodies cannot make calcium, so we have to get calcium through our diet or through supplements. It is really important. If there's not enough calcium in your blood, your body's going to react and start breaking down bone because it wants to use calcium all around your body for muscle contractions, regulating nerve function. Very important that we make sure we're getting enough calcium and vitamin D. This slide shows a couple sources. Most of these foods are fortified with calcium and or vitamin D. Salmon, tuna, trout, oily fish, really good for sources of vitamin D. Our need for calcium and vitamin D increases as we age. So it's really important that we pay attention to that and continue making sure we're getting that in our diet. Okay, there's no magic menopause diet. However, nutrition is key for supporting health during perimenopause and menopause, eating well, making sure that you are um, finding a diet that is balanced, that you can stick with. A good place to start is a Mediterranean type diet. We like this diet because it is a great blend of macronutrients, carbohydrates, proteins, fats. Also focuses on fresh fruit, vegetables, nuts, seeds, whole grains, monounsaturated oils like olive oil, and omega-3 fatty acids that we see in oily fish. These are all really, really important to help counteract some of the stuff that's going on with menopause. I do want to mention that there is emerging data on the role of gut health for overall health, and this is really important for premenopausal women, but also in menopause. And we talk about like prebiotics. Prebiotics are the non-digestible fibers and compounds that feed and stimulate the good bacteria in our gut. They enhance the gut microbiome, they improve calcium absorption, and they support our metabolic and immune health. We combine this with probiotics, which are those live beneficial bacteria that help maintain or restore a healthy diet and balance in the gut. It improves digestion, it supports immune function, and may reduce some of the symptoms of IBS, bloating, and even mood disorders. So again, when it comes to maintaining a healthy weight, estrogen is our ally. It supports fat and glucose, it curbs appetite, helps us hang on to lean muscle mass. So in perimenopause and menopause, when that estrogen starts to drop, we start to see weight gain. We see weight mainly in the central area, abdomen, upper thighs, buttocks. As we get older, our metabolism starts to slow down. So we're hitting this perfect storm of perimenopause, menopause, and age that really makes it much more difficult to maintain weight with the same level of eating and exercise. And so we're going to talk about exercise can help not just with maintaining weight, but it can help with mood, sleep, endorphins, energy levels, help prevent chronic conditions. We know that it can help with heart disease, osteoporosis. There are many things we can do. Strength training, really important for helping to build lean muscle. Cardiac activity, cardio, doesn't have to be high intensity. If you can do high intensity, it's very good. That can actually help with brain fog, decrease depression. Things like yoga can help with lowering blood pressure. And even walking. I love walking. Walking has so many positive aspects. You can do it alone, listen to a podcast, you can go with a friend, socialize, helps to lower blood pressure. I'm also of this idea that if you don't move it, you lose it. So getting out there and moving helps to keep your joints lubricated and really does a lot to benefit many things related to keeping ourselves active and engaged. Stress levels are high for women during menopause due to all the changes that are happening to our bodies. This stress causes cortisol levels to rise, and that can have a deleterious effect on our bodies overall. And we're all different. We all relax in different ways. Yoga may work. Um, Meditation really has been shown to be very effective. Meditation activates the parasympathetic nervous system. This helps to lower cortisol and has a calming effect on our bodies overall. And they've shown in studies that can actually reduce cortisol levels by 25%, which is huge. Also helps to manage anxiety, depression, mood swings. Really a lot of very beneficial things that can happen with meditation. Helps with brain fog, enhanced memory and clarity. So my takeaways here are menopause is different for everyone. We really feel like women should be able to talk about menopause if they want to. take away the stigma related to menopause. Um, we really want to build a community of people that can support each other, a safe space to talk about what's happening. If you're having issues with memory or brain fog and making your day-to-day tasks more difficult, it's really important that you can talk to either someone at work or your boss about that. Really want to encourage a healthy lifestyle, developing a support system either with a partner or a buddy so that you can do things together, and help to build some understanding and reassurance that menopause is normal. It happens to all of us. These changes are beyond our control. There are things we can do to mitigate it and come through this in a healthy way. And any of that decision making, like related to treatment for severe symptoms, should really be with a qualified healthcare provider. We want to make sure that we are creating some openness and shared experiences that really do help women normalize this process. And maybe creating some educational materials and sharing that can be another way to do this. And I've said a lot, and I'm going to turn it back over to you, Katie.
Dr. Robertson, thank you. Truly, this was a lot of great information, a lot covered here today. As you mentioned, hopefully everyone is able to take away at least something that they can implement. So with that being said, just based on the interest of time, there are some related benefits I will quickly run through. Please note the availability of some of these benefits does vary, so please check in with customer care to confirm availability. But the first one available to everyone is our Find a Doctor tool that is located on our Univera Healthcare online account. So whether you're using it through the web and or app, you're able to search for providers within your network that are, once again, maybe specific to OBGYN, women's health, etc. So great resource to be able to tap into. We also have a care management team here at Univera that includes healthcare professionals such as registered nurses, registered dietitians, etc., that are all here to support our Univera members at all ages for no added cost. So once again, if any additional interest or questions to receive support, personalized care plan for any of the conditions that you see listed here, or just looking to connect for health and wellness resources, you can easily connect with our care management team through phone, email, or as you see listed here, by downloading the free WellFrame app. The access code to use when creating that WellFrame account through Univera is Univera Welcome, all one word, all lowercase. And then the last platform I wanted to quickly touch base on. This does vary by contract, but some members have access to Vitalize, a digital well-being platform to help support tools, resources needed on your well-being journey. Some great resources specific to menopause, women's health, etc. So be sure to check that out if of interest. So with that being said, thank you once again, Dr. Robuchon. Thank you everyone for joining here today. We are interested in feedback. So my colleague Kate is actually going to put into the chat a short, brief 2-3 minute survey if each of you wouldn't mind taking that, providing us your feedback on this topic, but also future topics you are interested in hearing about. And then before moving into that Q&A, last plug here for the upcoming well-being webinar in November on the topic of demystifying diabetes. So that will be Thursday, November 20th at noon. Once again, if any interest in exploring this topic more in detail, please feel free to register through either the QR code here on this slide, or once again, my colleague Kate will put into the chat the registration code for registering for that upcoming webinar as well. So with that being said, let's move into questions. I apologize right at time, but a lot of info we went through there. So I did see a couple questions come through already, but once again, the reminder for anyone that has a question, please feel free to enter it into the chat or Q&A, whatever you see best. Quick question, Dr. Robuchon, that has come through. What hormone replacement would you recommend for individuals who have type 1 diabetes or a family history of issues?
That's a great question. And again, those sort of fall into the gray zone when we were talking about the risk for hormone replacement therapy or menopausal replacement therapy. It really would depend on a lot of those factors. And I go back to the ASCVD. What else is going on? Are there other things that we need to pay attention to other than just the type 1 diabetes? And how well has the type 1 diabetes been managed? If someone's had great control, They don't have any, diabetic retinopathy or peripheral vascular disease, and they're really suffering, I would think about it. I might talk about some of the other options to control whatever the symptoms might be. If it's truly hot flashes, we do know other things can work. It really is, like I said, it's this shared decision model. There's a lot of things that have to go into that for us to really feel comfortable making a recommendation. But I think talking to your provider and helping them to understand how much you're suffering or how symptomatic you are, that's part of what can help to establish this is the next best step.
Absolutely. Thank you for sharing those thoughts. I do not see any other questions that have come forth so far. So once again, last plug here. If any questions for Dr. Robichon while we have her, please feel free to enter them. And if not, once again, just thank you all for joining here today. Truly a lot of information, as somebody put into the chat. It's really nice to know we're not alone and not completely losing our mind. So once again, thank you for that little bit of light brevity there. But truly hope everyone was able to take something here today. Dr. Robichon, once again, thank you for your passion, knowledge, and expertise. And we
My
hope to
pleasure.
see everyone at, thank you, the next well-being webinar in November. And last plug for that survey, once again, if you wouldn't mind taking that few minutes. So thank you, everyone. Hope you have a wonderful rest of your day. Bye, everyone.
Thank you.